Welcome to the deep dive. We're jumping right in today because we have to set a scene that plays out like an absolute thriller.
Oh, it really does.
Yeah, so I want you to picture this. It is 2 o'clock in the morning. A 38-year-old woman just rushes through the doors of an emergency room.
Right.
And she is 32 weeks pregnant with her third child. By all accounts, she has been, completely healthy her entire life. But she just woke up with this sudden, severe chest pain that she says is radiating all the way through to her back.
Just out of nowhere.
Exactly. And she actually describes it as a tearing sensation. Like the absolute worst pain she had ever felt.
And see, that specific word tearing, it should immediately send a chill down the spine of anyone working in emergency medicine.
Really? Just that one word.
Oh, yeah. It is a massive, blaring red flag that something catastrophic is happening structurally and not just, a standard heart attack.
Well, and within minutes, the doctors are looking at data that points in two completely opposite directions. And following the most obvious medical reflex based on her lab results will actually kill her.
Which is terrifying.
It is. So that is the mission for our deep dive today. We are unpacking this really fascinating medical case script from the ICU files, and it's titled The Tear.
It's such a good case.
It is. We're going to dissect the critical care decisions made in those golden high-stakes hours and really explore how true expert critical thinking requires actively ignoring the most obvious surface-level answers to uncover the hidden mechanisms underneath.
Yeah, it is a phenomenal case study in diagnostic muddy waters because in a chaotic ER, the brain naturally wants to match a symptom to a textbook treatment.
Right, it's just human nature.
Exactly. But as we'll see, doing that without understanding the underlying physics of the human body can just be fatal.
Okay, so let's look at what the doctors were dealing with at 2 a.m. They pull her vitals, and the numbers are completely erratic. Her heart is hammering at 124 beats per minute.
Which is way too fast.
Way too fast. But looking at the source material, the blood pressure readings are what really jumped out at me. Because in her right arm, it's 178 over 106. But in her left arm, it's 142 over 84.
Yeah, that is a huge differential.
Right. I mean, why would it be so different?
So a 36 millimeter difference between the left and right arms is a critical piece of the puzzle here. The circulatory system is basically just a closed loop of plumbing.
Okay.
So if the pressure is that drastically different between two branches that should be receiving roughly the same flow, it tells you that something is physically blocking or altering the flow of blood before it even reaches those extremities.
Okay, so while they are trying to figure out that weird pressure difference, the lab results come back. And this is where that lethal reflex comes into play. Her D-dimer level is at 4,840.
Which is massive.
Right. And for anyone who isn't familiar, a D-dimer is a protein fragment. It basically shows up in your blood when a clot is actively breaking down somewhere in your body.
Yeah, and a normal number is usually under 500.
Exactly. So the intern on duty sees 4,840, looks at a pregnant woman with shortness of breath and chest pain, and immediately calls it a massive pulmonary embolism, a blood clot in her lungs.
Right.
And the intern's first instinct is to hit her with heparin, which is a really powerful blood thinner right away.
Which, honestly, under normal circumstances, makes perfect logical sense.
Because you want to break up the clot.
Exactly. If you have a deadly clot in the lungs, you thin the blood to stop the clot from growing and killing the patient. But the cardiology fellow in the room actually stops the intern from administering the heparin.
Thank goodness.
Seriously. The fellow looks at the tearing nature of the pain, that blood pressure difference between the arms we talked about, and does a quick bedside ultrasound showing a widened main artery. And he realizes they aren't dealing with a clot in the lungs at all.
They are dealing with a Stanford Type A aortic dissection.
Yes.
And I spent some time looking at the diagrams of this in our sources.
Yeah.
And it is terrifying.
It's the stuff of nightmares.
It really is.
Yeah.
Because the aorta is the massive main pipeline carrying every drop of oxygenated blood out of your heart. A dissection means the inner lining of that pipe has literally split open.
Right.
So now, with every single heartbeat, this high-pressure blood is forcing its way into that tear, ripping the layers of the artery wall apart and creating this fake secondary channel, right? A false lumen.
Yeah, that false lumen is the core mechanism of the entire crisis here.
Mm-hmm.
The wall of the aorta is basically splitting apart under the hydrostatic pressure of the patient's own heartbeat.
Wow.
And the fellow specifically identified a Stanford Type A dissection. That means the tear involves the ascending aorta, which is the section rising directly out of the top of the heart.
As opposed to a type B.
Right, which happens further down in the descending section. Type A is an absolute surgical emergency. I mean, without surgical repair, the mortality rate increases by 1 to 2% every single hour.
And the sources mentioned the cardiology fellow caught a pathognomonic sign, basically like a dead giveaway symptom just by listening to her chest.
Yeah, he heard a new murmur that sounded like blood falling backward into the heart.
So what exactly does that mean?
So that murmur is the sound of aortic regurgitation. Because the dissection is in that ascending section, the tear is actually ripping backward, down toward the heart itself.
Oh, wow.
Yeah, it reaches the ring of tissue that supports the aortic valve and stretches it so wide that the physical doors of the valve can no longer meet in the middle to close.
So they're just stuck open.
Exactly. So every time the heart pumps, a significant portion of that blood just falls right backward into the heart chamber. It confirms the tear has completely compromised the structural integrity of the heart's main exit door.
Okay, so the fellow's completely right about the dissection, but that leaves this massive lingering question about the intern's data. If it's a torn aorta, why was the D-dimer at 4,840? I mean, that's a massive number that usually screams blood clot.
So the intern fell into the trap of raw data without context. They completely failed to account for the physiological reality of a 32-week pregnancy.
Well, right, because pregnancy changes everything.
It changes everything. Throughout a normal pregnancy, the body naturally prepares for the blood loss of childbirth by slightly increasing its clotting factors, which in turn causes the D-dimer to naturally rise.
Okay.
So by the third trimester, a completely healthy pregnant woman will have a D-dimer 3 to 4 times higher than a non-pregnant person. It's really just background noise.
So using that lab test to diagnose a clot in a third trimester pregnancy is basically useless.
Completely useless. You cannot rule a pulmonary embolism in or out with it. And furthermore, the massive tissue trauma of the aorta tearing apart and the blood rushing into that unnatural false lumen, it triggers a massive emergency response from the body.
It's trying to heal itself.
Yes. The body is desperately trying to clot the blood inside that false lumen to heal the injury, which spikes the D-dimer even higher.
Which brings us back to the heparin. The intern was seconds away from pushing a powerful blood thinner. When I realized what heparin would actually do in this specific scenario, I was stunned.
It's crazy to think about.
Administering heparin here would be like greasing a slipping rope. The patient's natural ability to clot blood is the only thing keeping her alive at that exact moment.
It is an incredible biological defense mechanism. When the high-pressure blood rips into that false lumen, the body senses the catastrophic injury. It initiates spontaneous thrombosis.
So it's clotting on purpose.
Exactly. It aggressively tries to clot the blood that is trapped inside the torn wall. That clot is highly protective. It acts like a temporary physical plug, filling the gap and limiting how far the tear can expand.
Wow.
It stabilizes the weakened aortic wall so it doesn't just burst open completely.
So if the intern had pushed the heparin.
The heparin would have completely halted that protective clotting process.
Oh my God.
Yeah. The false lumen would remain wide open, fully patent, and completely subjected to the hammering, unmitigated pressure of her arterial blood flow.
Without the plug.
Without that natural clot acting as a brace, the false lumen would violently expand, the outer wall of the aorta would rupture, and the patient would bleed to death internally in a matter of minutes.
That is just wow.
The very drug meant to save her from a suspected lung clot would have melted away the only barrier keeping her aorta intact.
That is just wild to think about. It really highlights how terrifying the golden hours of emergency medicine can be. So, okay. We've avoided the lethal mistake. We know she needs her chest opened up and that aorta repaired immediately.
Right.
But she is currently sitting in the ER bed with a blood pressure of 178/106, and her heart is racing at 124 beats per minute. How do they stabilize the chaotic physics of her blood flow before she reaches the operating room?
Well, the immediate goal is to drastically reduce the mechanical stress hitting that torn aortic wall. The protocol for an acute aortic dissection demands an incredibly aggressive reduction in blood pressure.
How aggressive are we talking?
The target systolic pressure is between 100 and 120.
That is low.
That is remarkably low, especially considering that for almost any other hypertensive emergency, doctors usually aim for around 160 to ensure enough blood keeps reaching the brain.
Right, you don't want them passing out.
Exactly. But here, Every single millimeter of pressure above 120 is just extra physical force prying that tear further apart.
Wait, hold on. Her pressure is 178. If the goal is to get it down to 120 as fast as humanly possible, why are we overcomplicating this? Why not just hit her with a pure vasodilator? You know, a drug that instantly relaxes all the blood vessels, opens up the pipes, drops the pressure, and problem solved.
And that is the second major trap in this case.
Really?
Yeah. Giving a pure vasodilator right out of the gate is another reflex that ends in disaster.
Why?
To understand why, we have to look at the mathematical formula for aortic wall stress.
Oh, boy.
I know, math. But a physical stress on that torn tissue equals blood pressure multiplied by heart rate multiplied by a crucial factor called DPD2.
Okay, let's break down DPDT because that sounds like advanced calculus.
It's the change in pressure over the change in time. In physical terms, it represents the sheer force and velocity of the blood being ejected from the heart with every single beat.
Okay, so it's not just how much pressure, it's how fast it hits.
Yes. Is how hard and how fast the wave of blood slams into the aortic wall. If you give a pure vasodilator first, the blood vessels open up and the overall blood pressure drops instantly. But the body's nervous system senses that sudden artificial drop in pressure and absolutely panics.
Oh, I see.
It triggers reflex tachycardia.
So the heart thinks the body's bleeding out, so it kicks into overdrive to compensate.
Precisely. The heart starts beating significantly faster and it pumps much, much harder.
Oh, no.
So even though the overall static pressure in the pipes is lower, the velocity and the force of the blood wave, that DPDT factor, it skyrockets. You are now slamming blood against a fragile, torn aortic flap faster and more violently than before.
Which just ruins the tissue.
You end up shredding the aorta even quicker.
So you solve the pressure problem, but you create a high-speed hammering problem that destroys the tissue anyway.
Exactly. And that's why the strict medical protocol mandates the use of beta blockers first.
Oh, because they slow everything down.
Right. Beta blockers are unique because they tackle all three parts of that stress formula simultaneously. They gently bring down the blood pressure, they force the heart rate down to our strict target of under 60 beats per minute, and crucially, they directly reduce the contractile force of the heart.
So it doesn't squeeze as hard.
The heart physically squeezes less violently. By lowering the heart rate and softening the squeeze, you drastically reduce that dangerous DPDT hammering effect. Only once the heart rate is locked down with beta blockers can you safely introduce vasodilators to finish lowering the pressure.
Okay, so the hemodynamics are stabilized, the internal hammering is under control, she has to get to the operating room.
Right.
But there is a massive logistical nightmare waiting for the surgical team because there are two patients here.
Right.
The mother and a 32-week-old fetus. How do they choreograph a major cardiovascular surgery around a third trimester pregnancy?
Well, it all comes down to strict delivery timing guidelines based on fetal viability. If the mother suffers a dissection before 28 weeks, the fetus is generally considered too premature to deliver safely. Okay. In that scenario, surgeons will perform the open heart aortic repair on the mother and leave the baby in utero, hoping the fetus survives the bypass machine.
Wow. That is intense.
It is. Now, if the mother is past 34 weeks, the baby's lungs are mature enough that they will perform a cesarean section first, deliver the baby, and then fix the aorta.
But our patient is right in the medical gray zone. 32 weeks.
Exactly. Because she is at 32 weeks, the standard of care dictates a joint operation. They must perform a C-section immediately followed by a full open-heart aortic reconstruction, all under the exact same run of general anesthesia.
All at once.
All at once. There is simply no time to stage them as separate procedures on different days because of that 1 to 2% hourly mortality rate of the dissection.
Right.
And before they even wheel her down the hall, the obstetric team has to step in and administer an injection of betamethasone to the mother.
That's a steroid to rapidly mature the fetal lungs, right?
Right.
Because they know this baby is getting evicted from the womb several weeks early no matter what.
That's the goal. But as the cardiac surgeons map out their side of the operation, they encounter a terrifying paradox on the imaging.
Oh, great. What now?
The ultrasound shows a large pericardial effusion.
Okay, so what is that?
The pericardium is the tough, fibrous sac that surrounds and protects the heart. In this patient, blood has leaked out from the torn aorta and filled up that sac, creating immense pressure around the heart itself.
Okay, I have to stop you there because I've seen enough medical dramas to know exactly what happens next.
Oh, I know where you're going with this.
The patient's heart is getting crushed by fluid. The heroic doctor grabs a massive needle, jabs it into the patient's chest, and drains the fluid to relieve the pressure and save their life. It's pericardiocentesis.
Yep, the classic TV trope.
But in reading the sources, they explicitly state that doing that here would be a catastrophic mistake. Why wouldn't you relieve that pressure immediately?
Because of a phenomenon called protective tamponade. We have to visualize what is physically happening inside her chest. Yes, there is blood trapped in the sac crushing the heart, but that blood is under high pressure, and that pressure is pushing back against the outside of the torn aorta.
Oh, wait.
Yeah, the fluid is acting like a tight physical brace wrapping around the damaged vessel. It is literally pressing from the outside in, helping to hold that false lumen close.
Oh, wow. So the very fluid that is suffocating the heart is actually the only thing keeping the aorta from completely exploding?
Precisely. If you stick a needle in and drain that blood in the ER, you instantly remove the brace. The external pressure vanishes, the false lumen violently expands outward without any constraint, the aorta completely ruptures, and the patient bleeds to death on the table in seconds.
That's insane.
You cannot touch that fluid until her chest is surgically open, she is connected to the cardiopulmonary bypass machine, and the surgeons are fully prepared to clamp the aorta.
It's just another reflex you have to completely suppress to save her life.
Yeah.
So the choreography begins. They get her into the OR. They successfully deliver the baby via C-section, and the cardiac team takes over to repair the aorta. But a tear this massive doesn't just damage the heart. It causes secondary damage downstream, right? The sources mentioned malperfusion syndrome.
Yeah. Think of the aorta like the trunk of a tree, with branches feeding every major organ in the body. The imaging showed that the tear extended so far down that her right renal artery, which is the branch that supplies all the blood to her right kidney, was actually feeding off the false lumen.
Oh, so it wasn't getting normal blood flow.
It was pulling blood from the unnatural tear, not the true channel. When the surgeons replace that damaged section of the main aorta with a synthetic tube, they are intentionally obliterating that false lumen.
Which means the right kidney suddenly loses its entire blood supply.
Exactly. The right kidney will suffer severe damage from lack of oxygen. And managing a kidney injury in a patient who just had open heart surgery is incredibly delicate.
I can imagine.
Standard dialysis machines clean the blood very quickly, but they cause rapid shifts in blood pressure and fluid volume. A freshly stitched, recovering heart just cannot handle those aggressive swings.
So what do?
So in the ICU, they utilize continuous renal replacement therapy, or CRRT. Instead of a fast, aggressive cleaning, CRRT gently and continuously filters the blood 24 hours a day, keeping the fluid levels perfectly stable so the heart isn't stressed.
And what happens to the aortic valve itself? We know that dissection ripped backward and stretched the valve out, causing that murmur we talked about earlier.
Well, in many dissection cases, the physical doors of the valve, the leaflets, are actually perfectly healthy.
Oh, really?
Yeah, they were just pulled apart when the ring supporting them was stretched by the tear. Surgeons can often perform specialized procedures where they replace the damaged pipe with a synthetic graft, and that graft gently pulls the structural ring back to its normal, tight diameter.
And then it just works again.
Exactly. The patient's native valve leaflets suddenly meet in the middle and function perfectly again.
But the sources noted that they couldn't do that here. They had to completely swap out her entire aortic root and her native valve for a mechanical one.
They did. And the reason they had to discard her native valve brings us to the ultimate root cause of this entire terrifying ordeal.
Right, because we need to look past the immediate plumbing fix. We have to ask the bigger question. Why did a healthy 38-year-old woman's aorta just shred in the first place?
Right.
And the answer wasn't a sudden trauma or a bad lifestyle choice. The answer had been hiding silently in her DNA for her entire life.
Yeah, following the surgery, genetic testing confirmed that the patient had Marfan syndrome. This is caused by a mutation in the FBN1 gene.
The FBN1 gene.
Yes. That gene is basically the instruction manual that tells the body how to produce a protein called fibrillin-1, which is absolutely crucial for giving connective tissue its strength and elasticity.
I was trying to visualize what this means for her body. The surgeons did this miraculous job replacing the burst pipe in her chest with a synthetic graft. But this Marfan diagnosis means that structural support beams in the rest of her entire body are essentially made of balsa wood instead of steel.
Yeah.
Like she has weak tissue everywhere.
That is an excellent way to conceptualize it. Her connective tissue is fundamentally fragile. When doctors reviewed her earlier imaging, they found that her aortic root was already dilated to 4.8 centimeters before it even tore.
It's just big, right?
Very big. In a person without Marfan syndrome, surgeons usually don't intervene until an aneurysm hits 5 or 5.5 centimeters. But because Marfan tissue is so weak and prone to catastrophic tearing, the threshold for preventative surgery is much lower, usually around 4.5 centimeters.
So she had an aneurysm sitting right above that surgical threshold, and she had absolutely no idea.
None.
She was walking around with a faulty support beam, just waiting for the wrong amount of pressure to be applied. So she survives this incredible surgery, but she still has Marfan syndrome. What does her lifelong management actually look like?
It requires intense multidisciplinary surveillance. The cardiac team fixed her ascending aorta, but the entire rest of her aorta, the arch at the top, the descending section going down through her chest all the way into her abdomen, is still made of that fragile Marfan tissue.
Right, they couldn't replace all of it.
No, so she will require highly detailed MRI or CT scans every 6 to 12 months for the rest of her life to monitor for new ballooning aneurysms or secondary tears.
And because it's connective tissue, it's not just her blood vessels that are at risk.
Exactly. Connective tissue holds everything together. She will need strict annual exams with an ophthalmologist.
Really? Her eyes?
Yes. The microscopic fibers that hold the lenses of our eyes in place are made of connective tissue. In about 60% of Marfan patients, those fibers are so weak that the lens of the eye literally dislocates from its proper position, severely impacting their vision.
That is wild. And how do they medically protect the rest of her faulty aorta from tearing again? Are they just relying on the beta blockers?
Well, beta blockers remain a lifelong necessity to keep that mechanical DPDT hammering force low. But standard care now utilizes a dual medication strategy. She will also be prescribed a drug called losartan.
I've heard of losartan. Isn't that just a run-of-the-mill blood pressure medication? Millions of people take it.
It is widely used for blood pressure, but in patients with Marfan syndrome, it serves a highly specific, extraordinary purpose. The Marfan genetic mutation doesn't just make the tissue physically weak, it causes a cellular dysregulation in a specific signaling pathway in the body.
Okay, so on a molecular level.
Right. This pathway becomes wildly overactive, triggering chronic inflammation that structurally degrades the aortic wall over time. Major clinical trials discovered that losartan chemically blocks that specific inflammatory pathway.
Oh, wow.
So her treatment is two-pronged. Beta blockers shield the aorta from mechanical stress, and losartan shields it from molecular inflammation.
It's amazing how targeted that is. But there is a heavier reality to this genetic reveal. Marfan syndrome is hereditary. This isn't just about protecting her anymore.
No, and that is where the scope of this deep dive really zooms out. Because it is a dominant genetic mutation, the infant daughter she just delivered has a 50% chance of carrying the exact same faulty gene. That newborn requires immediate genetic testing.
Which has to be a terrifying concept for a mother who just survived an operation like this.
Unquestionably terrifying. But the silver lining here is that discovering this mutation, even through a catastrophic event, acts as an incredibly powerful protective warning system for her entire family tree.
Yeah.
So many Marfan diagnoses are only made in the autopsy room after someone suffers an unexpected fatal dissection. Because she survived, doctors can now perform cascade genetic testing on her parents, her siblings, and her children.
Meaning they can find out right now if her newborn daughter has it, put her on those protective medications early, monitor her structural growth, and ensure she never has to face her own 2 a.m. surgical nightmare.
Exactly. Knowledge in this scenario is literal protection.
But the knowledge also comes with a really heartbreaking medical mandate for the mother. The doctors strongly counsel her that she can never have another child.
Yeah, future pregnancies are considered a strict medical contraindication for her. There are two major life-threatening hurdles. First is the hemodynamic stress. Pregnancy drastically increases the volume of blood in the body and forces the heart to pump harder and faster.
Which is exactly what we don't want.
Right. That is the exact biological stress test that caused her fragile Marfan aorta to tear in the first place. Subjecting her remaining faulty aorta to that stress, again, carries an unacceptably high risk of a second fatal dissection.
And the second hurdle is the new mechanical valve in her heart.
Exactly. Mechanical heart valves are notorious for causing blood clots, so patients must remain on aggressive, lifelong blood thinners to keep the machinery moving freely.
Okay.
The absolute gold standard drug for this is warfarin. But if she were to become pregnant, warfarin is highly toxic to a developing fetus. If taken during weeks 6 through 12 of a pregnancy, it can cause severe facial deformities, bone growth abnormalities, and developmental delays in the baby.
So in a hypothetical future pregnancy, couldn't they just take her off the warfarin and use heparin again? We established earlier that heparin works as a blood thinner, and it generally doesn't cross the placenta to harm the baby.
They could temporarily substitute heparin, but it creates an agonizing medical dilemma. Heparin is vastly inferior to warfarin when it comes to preventing clots on a mechanical valve.
Oh, I see.
So while you might protect the fetus from birth defects, the mother's risk of developing a massive, rock-hard clot on her heart valve skyrockets.
Wow.
Yeah, that clot could jam the valve or break off and travel to her brain, causing a massive, disabling stroke. You are forced to choose between risking the development of the fetus or risking the life of the mother. It is a no-win scenario.
Though it is important to note from the sources that warfarin is perfectly safe for breastfeeding her current newborn.
Yes.
The drug binds heavily to proteins in the mother's blood, so it doesn't actually transfer into the breast milk in any meaningful amount.
That is a crucial comfort. She can safely nurse and bond with her new daughter without passing on the risks of her medication.
Which is a beautiful piece of relief at the end of an incredibly harrowing journey. And it brings us to the core lesson I took away from these ICU files. We live in a world of information overload, where our brains are constantly wired for rapid, algorithmic reactions.
Very true.
You know, we see a high D-dimer, we want to give a blood thinner. We see fluid crushing a heart, we want to drain it. But true expertise is knowing when the most obvious textbook answer is actually the wrong one.
It's about ignoring the reflex.
Exactly. We learned today that forcing yourself to pause, to look past the surface data, and to understand the deep physical mechanisms at play, whether it's realizing a blood thinner will melt away a protective clot or understanding the bizarre paradox of fluid bracing a tearing artery, is what actually separates a standard response from one that truly saves a life.
It is a profound reminder that critical thinking requires us to hold multiple, often conflicting variables in our minds at the same time. The human body is rarely a simple equation.
It really leaves you with a lot to chew on. And I want to leave you, our listener, with one final lingering thought to explore on your own. We just saw how a life-threatening genetic structural flaw hid silently inside a perfectly healthy-seeming woman for 38 years. It took the specific, intense biological stress of a third trimester pregnancy to finally pull the trigger and reveal it.
Yeah.
So it makes you wonder, what other invisible genetic traits or hidden vulnerabilities might each of us be carrying right now, woven into our own DNA, just quietly waiting for the exact right environmental stressor to wake them up?